I have a bad feeling about this.
Homocystinuria is an autosomal recessive disorder which causes accumulation of homocysteine in the body. There are several causes of homocystinuria, and to explain them all, we have to know the pathway of homocysteine in the body.
What does that got to do with anything?
Everything.
In our body, we can metabolize homocysteine by two pathways. The first option, we can convert homocysteine into the methionine with the help of homocysteine methyltransferase. This reaction is complicated because for this reaction to occur, we need methylated vitamin B12. Basically, it's vitamin B12 that carries methyl group. And to make methylated vitamin B12, we need methylated tetrahydrofolate. And methylated tetrahydrofolate we produce from folate with the help of a crucial enzyme, methylene tetrahydrofolate reductase. The second pathway is to convert homocysteine into the cystatin. This reaction is catalyzed by the crucial enzyme cystatin synthase. And we have to know that the cofactor of cystatin synthase is vitamin B6, so-called pyridoxine. After this, we convert cystatin into the cystine, and cystine we metabolize into cystine. Cystine we excrete from the body by the kidneys. But we have to know that some part of cystine undergo reabsorption via proximal convoluted tubule amino acid transporter back into the blood. And cystine molecules which were not reabsorbed we excrete into the urine. But sometimes something can go wrong.
What is it?
And there are several potential causes of homocystinuria.
How can this be?
The most common cause of homocystinuria is deficiency of cystatin synthase. Without cystatin synthase, we cannot convert homocysteine into the cystatin. This causes accumulation of homocysteine in the blood. Because the cystatin pathway does not work, now more homocysteine molecules begin to metabolize into the methionine. And as a result, the concentration of methionine in the blood increases. The excess of homocysteine we excrete by the urine. Increase in concentration of homocysteine in the urine we call homocystinuria, so it's where the name of the disease comes from. But the ability to excrete the excess of homocysteine is limited, and with time, defect in cystatin synthase cause progressive accumulation of homocysteine in the blood. First of all, excess of homocysteine in the bloodstream leads to increase in reactive oxygen species production, which results in oxidative injury. And there are two most susceptible tissues. First of all, it's endothelial cells. Accumulation of homocysteine causes endothelial cells dysfunction, which significantly increases the risk of atherosclerosis. In addition to this, endothelial cells dysfunction significantly increases the risk of platelets activation, which can cause thrombosis. The second tissue which becomes affected by homocysteine accumulation is skin. Accumulation of homocysteine in skin causes severe oxidative injury, and the most susceptible cells to oxidative injury in the skin are melanocytes. Melanocyte injury causes decrease in melanin production, which results in hypopigmented skin. Accumulation of homocysteine in the blood also causes decrease in collagen and elastin production, which leads to connective tissue injury. First of all, connective tissue injury affects joints and bones. With time, homocystinuria can cause development of osteoporosis, kyphosis, and morphonoid habitus. In the eyes, connective tissue injury affects lens. It causes lens dislocation in a very specific pattern, down and in. And lens dislocation is one of the most important diagnostic features of homocystinuria, so we have to know this. Additionally, we have symptoms related to accumulation of methionine. Increase in methionine concentration disrupts methylation reactions. And because methylation reactions are involved in RNA and DNA synthesis and repair, disruption of methylation reactions affects the state of DNA and RNA molecules. Combined, this leads to a severe damage to neurons, which in child can cause severe intellectual disability. Also, as we see, without cystatin synthase, we cannot produce cystatin, we cannot produce cystine, and we cannot produce cystine. So, the level of these amino acids in the blood will decrease. How we can correct this state? First of all, we can improve the function of cystatin synthase by prescription of vitamin B6. Also, we can decrease the severity of neurological damage by restriction of methionine intake. In addition to this, we can increase the dietary consumption of cystine, just to correct the level of this amino acid in the blood. And last but not least, to improve the function of homocysteine methyltransferase, we can prescribe vitamin B12 and folate. By this, we can convert some amount of homocysteine to methionine, which will help us to decrease the level of homocysteine in the bloodstream. Now, let's discuss other possibilities which can cause increase in homocysteine level. The second possibility is homocystinuria caused by pyridoxal phosphate deficiency. Because vitamin B6 is the cofactor of cystatin synthase, with vitamin B6 deficiency, the activity of cystatin synthase decreases. This causes accumulation of homocysteine in the bloodstream, and with time, with accumulation of homocysteine, the level of methionine will also increase. In addition to this, without cystatin synthase, the production of cystatin and cystine decreases. To correct this, we can prescribe vitamin B6 supplements, which will improve the function of cystatin synthase. And also, we have to recommend to increase dietary consumption of cystine, just to correct the level of this amino acid. Homocystinuria can also be caused by deficiency of homocysteine methyltransferase, or we call this enzyme methionine synthase. Without homocysteine methyltransferase enzyme, we cannot convert homocysteine to methionine. As a result, the level of methionine decreases, and at the same time, the level of homocysteine increases. In this state, our goal is to correct methionine concentration in the bloodstream, and the simplest way to do this is to increase methionine consumption with diet. The fourth possibility is deficiency of methyl tetrahydrofolate reductase. Without methyl tetrahydrofolate reductase, we cannot produce methylated folate. Without methylated folate, we cannot form methylated vitamin B12. And without methylated vitamin B12, homocysteine methyltransferase cannot work. As a result, the concentration of methionine decreases, while the concentration of homocysteine increases. In this case, the only therapeutic approach is to increase the intake of methylated folate, which will provide the formation of methylated vitamin B12, and thereby this will increase the activity of this reaction. In addition to homocystinuria, we have cystinuria, which is a totally separate disorder.
This is getting out of hand. Now there are two of them.
But they both share the same metabolic pathway. Cystinuria is also autosomal recessive disorder, and cystinuria is caused by hereditary defect of renal proximal convoluted tubule amino acid transporter and also intestinal amino acid transporter. Without both these transporters, we cannot reabsorb cystine, ornithine, lysine, and arginine. You can memorize this as COLA. Without cystine reabsorption in the kidneys, the concentration of cystine in the urine increases, which leads to a precipitation of cystine with formation of cystine stones in the kidney tubules. So, let's explain the pathogenesis of cystinuria. In cystinuria, proximal convoluted tubule amino acid transporter does not work. As a result, we cannot reabsorb cystine from the kidney tubules. This causes increase in cystine concentration in the urine. In this case, there will be 2 extra cystine molecules, and increase in cystine concentration in the urine we call cystinuria. The major problem here is that cystine is a very sticky substance. So once the concentration of cystine molecules increases, they begin to stick to each other. This process we call precipitation, and precipitation results in formation of hexagonal cystine stones in the kidneys. We have to know that the more acidic is the environment, the higher is the rate of precipitation, and thereby the higher is the rate of kidney stones formation. So how we can prevent formation of cystine stones? First of all, the easiest way is to create a more alkaline pH in the urine. We call it urine alkalization. And for this purpose, we use potassium citrate and acetazolamide. The logic is that the more alkaline is the urine, the higher the pH, and thereby the lower is the rate of cystine precipitation. In addition to this, we can use chelating agents, which provide increase in solubility, and by this they markedly decrease the rate of cystine stones formation. Cystinuria can be detected by 2 methods. It's urinary sodium cyanide nitroprusside test and urine spectrometry. In treatment, in addition to urinary alkalization and chelating agents, patients should have a good hydration, and we have to recommend a diet low in methionine.
May the Force be with you.